As therapists, we are often faced with clients who have a complex presentation, possibly with an attachment disorder from childhood that has lingered with them and it has affected their ability to attune with others, to function as others might do so in a healthy way in everyday life. I have been asked a particular question by a team of therapists in a service, and I'm going to answer it in this video. If you would like to join us, please stay with us. I'm Dr. Michael Paterson, clinical psychologist and EMDR Europe accredited senior trainer. The question I have been asked by this particular therapy service is the following. Many of the children and adults we work with therapeutically have experienced distressing events and high levels of adversity. Perhaps they do not meet the strict criteria of PTSD, but perhaps they re-experience these events or avoid the triggers where possible. We know such events of a traumatic nature can have huge impact on attachment, attunement, and their general childhood and adolescent development. These experiences may form some of the key components in the formulation of their current difficulties. Can you please outline how you might go about formulating with a client with these sorts of experiences and give an outline of a treatment plan, including the role of EMDR? I often say to people who are training in EMDR therapy, we don't set aside what we already know when we come to EMDR therapy. You as a therapist will be familiar with Maslow's hierarchy of needs. It gives us a great understanding of what people's needs would be before they can move to the next level. As a reminder, let's have a look at Maslow's hierarchy. As you can see at the bottom of Maslow's hierarchy, there are the physiological needs. The roof over the head, food in the stomach, able to sleep, able to go to the toilet. Safety needs come after that. The first level must be in place before the safety needs can be met. Safety needs then have to be in place before that sense of love and belonging. Similarly, they need to be in place before we can have that self-esteem. That needs to be in place before we can reach self-actualization. When I'm assessing a complex client, I'm thinking, what are the client's needs? What has not yet been met based on Maslow's hierarchy? Are there physiological needs that have to be met first? If so, practical things need to be put in place. Safety needs come thereafter. Again, these could be practical issues that don't require any therapeutic intervention as such. But one of the things I would consider then would be the needs of the child part of them. I've listed in this next slide the different things which I would consider important in working with those complex clients. There are the needs of the inner child. There is another video in this series which explains how to work with the inner child and help meet those needs. Working with different ego states is another thing that I would do. This isn't something that I would do generally with somebody who would be well adjusted, having had good enough parenting and well enough resourced. But this is the person who maybe dissociates pathologically. The person who would have state switches and one part of them may not know about the existence of another. Or in different situations, they're acting like different people. Affect regulation skills would be another thing. Often our complex presentation clients will have difficulty regulating their affect. We need to spend time helping them develop those skills. Another thing is resources. Often our more complex clients will be lacking resources. They might have difficulty with simple situations like going into a local shop to buy a loaf of bread. In another video in this series, I talk about how to resource our clients in an effective way. I'll provide a link to this at the end of this video. Very importantly, what we need to do is keep our clients within the window of tolerance. This is not being hyperaroused or hypoaroused, such as in the following slide. You can see from this slide the red area is hyperarousal, the blue area is hypoarousal. If the client can stay within this window, then they have got one foot in the present and one foot in the past. It keeps them contained. They can have a dual awareness of being safe in the here and now while connecting to the disturbing memory for processing. With this window of tolerance, it can vary in its width. Imagine our clients who present. They can range from the well-adjusted clients at this end of a continuum of complexity to the most complex client presentation at that end. At this healthier end, the window of tolerance is wide. The further along the continuum of complexity we go, the window of tolerance gets narrower and narrower until it is a very narrow window for the most complex client presentation. Our role then as the therapist is to widen that window sufficiently so that our clients can process memories. I've talked about preparation phase for the client, understanding what the client might need. But how do we know which targets to process with EMDR therapy? When a client presents, I listen to what the difficulties are the client is experiencing in the here and now. Then I think, what experiences has this client had in the past that has led to them having the difficulties in the here and now? I identify the memory networks in which these experiences are stored. You can think of a memory network as looking like a hand, such as in this slide. There are different channels of information. They are associated with each other. One channel will have the sensory aspects of the experience, the sights, the sounds, the smells, the tastes. Another, the thoughts that they had at the time of that experience. Another, the emotions. The next one is physical sensations. And then another channel, a negative belief about themselves that is associated with that particular memory. What I try to do then is identify the memories that are there, starting off with the touchstone memory, that earliest recalled experience of the client's presenting problem, identifying the other past events, trying to cluster them where appropriate, so that there are similar situations which are linked together, such as criticisms from a parent or beatings from a parent or bullying that may have occurred at school. Then we consider the present triggers, and thereafter the client's desired outcomes for the future. The thing to remember, for every present trigger there will be a future template. So working with your clients with this complex presentation is not insurmountable. Break it down into manageable chunks. Think what has happened in the past that has led to this person having the difficulties in the here and now. Identify those. Once you have done that, those are the target memories for processing. Remember too, in terms of the preparation phase, is what does this client need? Think about Maslow's hierarchy. Use that as a checklist just to remind you what to install for that particular client. With the client's needs met, and the client now being stable enough, it would be safe to proceed to processing. Whether you would start off using EMD, eye movement desensitization, to keep the client contained, or using the standard protocol would be a clinical choice. But the thing to remember is we need to keep our clients safe. There is another video in this series about choosing between the standard protocol and EMD, keeping the client contained versus allowing the processing to go where it can go if you allow it. I hope this video was helpful to you. If so, please click like down below. If you haven't already subscribed to this channel, please do so. It is free. YouTube can then let you know about other videos I place in the series. I want to help you become the best you can possibly be in delivering EMDR therapy. Together, you and I, we can make a big difference in the world. Thanks for watching.